Good afternoon, everyone. I am so excited to be here today. My name is Amanda Marino. If you are just coming across this and you didn't sign up or register, and I'm here with a dear friend, colleague, and someone who I admire and look up to, Mr. Dr. Aldo Morales. You want to say hi to everybody?
Hello.
So Dr. Morales is my favorite psychiatrist. Personally, I've seen psychiatrists since I was 7 years old. Professionally, I work with psychiatrists often, and in mental health and the substance use disorder and digital addiction space. It's really important to have a psychiatrist that really gets it. I feel like a lot of them are kind of out of touch on what is really going on, and it's not their fault. Maybe they haven't had the proper education. So we do want to leave this open. I do want to let Facebook and LinkedIn know that this is an open forum. Please come in the chat, say hello, ask any questions for Dr. Morales. I will also include after this, or Blake can maybe do it for me, like your Dr. Morales's website if you want to work with him or use him as your psychiatrist or someone for a client. He's the best. And also a super cool person, a musician, very down to earth. And I just love having you in my corner and in my life. And I'm extremely grateful for you.
Thank you.
So would you like to say a little bit about yourself before I go into some of the Q&As that I have prepared for you? Who are you?
Okay, well, actually, I didn't know I was going to do addiction. I discovered it by chance because I did an elective as a resident. I did an elective in addiction psychiatry. Had I not done that elective, I wouldn't be here today with this subspecialty.
Yes.
Even today, it's not a requirement for doctors to be trained in addictions. You would think that with the problem we have nationwide, that medicine would have risen to the occasion and have gotten on board already, but that's not the case.
Absolutely. And that's the first question, which is the title of our presentation today, our Q&A and our collaboration is, what do doctors know about addiction? So what do they know about addiction in your experience? And
Jack, oh, wait a minute. I can't say that on a podcast.
Say whatever you want.
Well, actually, they know nothing and they know a lot. If you speak to someone who hasn't had any training, they know nothing about addiction. But there are addiction medicine doctors and addiction psychiatry doctors who've been trained. And we know quite a bit now compared to years ago. But your typical doctor out on the street is not going to know about this because they never had any training in it. We are now beginning to provide training to doctors and medical students. And it's not everywhere. It's just beginning to happen. And so they're getting some of the basics. Your general doctor, your general psychiatrist, but not everybody's trained. And we need to train all doctors because addiction is everywhere.
Yeah, it is. So what when you were in medical school, what was required as to learn about addiction, or was it required at all? I know you said something about elective course.
No, well, when I trained back in the 1800s, nothing was required. And today, for example, at FAU, the internal medicine residents are now required to do 1 week out of their 3 years of training. They get 1 week of training. And that might sound like not enough, but let me tell you, it's great. In that 1 week, I cover a lot of ground with them, and I open their eyes to the window of this world of addiction that they would have known nothing about. So now they can enter into their profession, and when they encounter patients in their daily practice of medicine, they'll know what to do, they'll know where to refer them, and it won't be so strange.
Yes.
Right now, addiction is a totally foreign topic to doctors. That's why AA was founded outside of medicine.
Absolutely. So you are currently in the office at a college, and what have you been? I mean, you're a change maker. You're you try to be, I feel like, you try to help people in a way that others don't. So like, what is this change that you're being part of at this school? Like, what are you doing?
I'm not the center of the change. I guess I'm the one fostering the situation, but there's a movement nationwide to educate all doctors in addiction. And some schools are slower to join the jump on the bandwagon. But for example, in internal medicine, it is now required that they do some training in addiction. And this is brand new. This just happened over the past couple of years.
That's crazy. That's crazy to
me. And in psychiatry, you would think that it would be mandatory. But as of now, it is not a mandatory requirement in all the training programs.
So someone can become a psychiatrist and not be trained on addiction.
That's correct.
That is crazy.
And I have many colleagues working in the community, in psychiatry and in family practice and internal medicine, who don't know how to handle an addiction case because they never had any training in it.
Right.
But we're slowly changing it. They are now becoming aware.
That's wonderful that it's starting. I feel like it's a million years too late, but better now than ever. And thank you for being someone that fosters that change and knows the importance of it. So this is the thing. How many people, which I'm going to assume is an extremely high percentage, would come to their doctor or their psychiatrist with their addiction struggles? That's a lot of people's first point of contact, right? They're going to trust their doctor. And if you're coming to your medical doctor or your psychiatrist and they don't know how to help you and don't have the training in this, like that's failing us, that system.
They need to know. And sometimes a patient could be under the care of a doctor. For example, if a patient gets admitted to a hospital, they don't know the doctor. They were admitted through the emergency room, for example, and they have a medical condition going on. And if the doctor is not aware that they have to look out for complications of addiction with this patient, the complications are going to just come jumping up at you and compromise the care of that patient.
Absolutely. I think that I wonder if you agree that doctors that are in the emergency room kind of have on-the-job training when it comes to addiction because they deal with a large amount of that. I know my primary doctor would work some shifts at JFK in the ER, and primarily people were there with, a large portion were people with addiction struggles that brought them in the door. So they get on-the-job training over there.
They get on-the-job training, yeah.
So what does it look like? What does it look like now that you're doing with current students? Because I know that there's a number of days I speak to you a week where you have residents that you're working with, one-on-one or a few of them at a time. What does that process look like now that you're fostering? And this is through FAU, correct?
Correct. Okay. Well, the process is new because we just started this year.
Wow. Good for FAU.
Yeah, I started with FAU several years ago, and we started with medical students. But now the residents are getting in they're getting in on the act, and so it's brand new.
That's great.
I think it's going very well. I think these guys and gals, they're all very bright. They're inquisitive. They want to learn, and I'm opening a window that they never knew existed there before, and they're looking in and saying, "Wow."
Yeah, the future's brighter with them having this education. And have any of them had ever experienced it or had anyone they've known, or is this all fresh new information for a lot of them? Hello?
Everybody. It resonates with everybody. And even if they don't have someone very close to them that they have firsthand experience with addiction, their patients do, and they know that because they're working with patients that have addiction problems or have had addiction problems.
So what is some of I know that your residents there are people that are watching. I would love to have you chime in and comment anything you've learned.
I hope they're there.
I hope they're there.
If they are,
I'd love to hear.
they can chime in. Look, let me tell you one thing I was discussing with one of them yesterday. I said to them, we in addiction treatment, we never give an addictive medication to a patient who has ever had an addiction problem. And I said to them, this is one rule that I want you to learn. This is a rule that you cannot break until you've mastered the rule totally.
Okay.
For example, Let me digress for a minute. In
Well,
my
Philip says hello. He's here.
Oh, hi, Philip. Philip is a psychiatry resident.
Awesome. So happy to have you, Philip.
All right, so listen to this story. Maybe it'll resonate.
Yeah, absolutely.
In my previous career of music, I had a music teacher who taught music theory, and she would give us a melody, and we had to provide the harmony and the counterpoint and all the rhythm and all that. So she gave us an assignment, and this was way back when, and I was into rock and roll at the time. So I crafted the piece of music that she gave us in a rock and roll manner, and I said, wow, this is cool. Look what I'm doing here. And I turned it in, and she failed me. I got an F. And I said, what do you mean? This is great stuff. Listen to this. And she goes, no, I'm failing you because you broke this rule and that other rule, and I haven't even taught you these rules yet. So you can't break the rules you don't know. Now, in medicine, I've broken this rule of giving an addictive medication to a patient with a history of addiction. I break the rule maybe once every 5 years. Okay. And half the time I break it, maybe 3/4 of the time that I break it, it comes back to bite me. Okay. So the moral of the story from my residents is, don't break the rule until you know it. And when you do know it, be very careful about breaking the rule.
And what would be?
Well, for example, a typical thing is a patient with an alcohol use disorder that has also a generalized anxiety disorder. They go see their family doctor. The doctor gives them a prescription for Xanax. Before you know it, this patient is going to have a Xanax problem.
Yes, absolutely.
Before you know it.
Yes.
So these are the things they're learning.
Absolutely. And I'm sure that's extremely helpful for them because, I remember being 23 years old and I had an internal medicine doctor that literally I could just ask for anything and he would give it to me.
Yeah.
I'm in personal recovery for 16 years and, I knew how to, at 23 years old, I didn't need, multiple pain medications and multiple anxiety medications and all of these things that I was able to get unlimited prescriptions for. Yes, things have shifted and changed, but there still are doctors that, maybe don't look at what other medications someone on if they counteract or don't have that experience and that background that
they don't know, but there's a history about this too. For example, we have a benzodiazepine epidemic right now. It's under the radar because the opioid epidemic takes center stage. Yes. But there's a benzodiazepine epidemic. Benzodiazepines are like Xanax, Valium, those kind of drugs. And one of the reasons we had the epidemic is that prior to the benzodiazepines, the only sedative we had was the barbiturates. And the barbiturates were dangerous because if you took a little too much of it, you would die.
Wow.
And many people accidentally took a little too much and died, or they mixed it with alcohol, and there was a lethal mixture, and they would end up losing their life. So when benzodiazepines were invented, the first one invented was Librium in 1960.
Okay. Fun fact.
And what happened was a patient could take an entire bottle of Librium and they would not die. It's not easy to kill yourself on a benzodiazepine. It's very, very difficult. Right. So doctors saw that and they said, wow, look at this. We have an agent here that doesn't kill people. So we can give it freely, right? And everybody and their brother was put on benzodiazepines. And every little old lady out there now is on benzodiazepines and at risk for falling down and breaking their hip.
Yeah.
These are the complications we inherited from previous generations of physicians, you see.
Absolutely. Do you think that some of the, like when you say there's a benzodiazepine epidemic, I feel like, do you think some of that has come from, the COVID time, the shootings, kind of like all of the life things that like people's anxiety is out there?
COVID has made everything worse.
Right.
The suicide rate went up. The overdose rate went up. The anxiety rate's gone up, depression. COVID changed the entire landscape.
Absolutely.
So everything has become exacerbated.
What have you seen in patients and since that time, like just everything in the rise? And I feel like that people that were on the edge really went off the deep end. People that thought they were okay got on the edge. I feel like, I know I changed my whole entire life post-COVID. Like everything in my whole life has changed since then. Because sitting with self, like I didn't realize that for 4 years I was on autopilot and just didn't let myself feel. And then I had to be still. And I was like, oh boy. We started a business our business in March of 2020 on paper, and
Oh,
literally have been
yeah.
so busy because of the struggles of people, and we work with Dr. Morales on some of our cases, and you're our psychiatrist as far as I'm concerned, even though other people do work with you too. But, we've seen everything's a little bit more complex now, and that's why I think the education is so important for individuals to
Yeah.
have.
Stress is detrimental to the human condition. So whenever you're under stress, you have a higher likelihood of coming down with complications of stress. And the mental health is no stranger to that. Mental health has suffered ever since COVID because everything became harder.
It did, and
Everything
scarier.
became harder. Everything became harder.
Yeah, and scarier. And then if there's, as a parent, you take your kid to school, and you see what happens every single day. Like, that's also terrifying. There's just a lot of things that I don't watch.
With the shootings, you mean? Yeah.
Yeah, I don't watch the news.
No,
It's not helpful for my mental health.
Yeah.
So how long do the resident psychiatry or medical spend with you, and what is a day to day look like?
Well, how long do they spend? Not long enough, but long enough to have a window into this world, and long enough to understand it and respect it, and know that they can refer patients to a specialist if they need to. They spend anywhere from a week to a few months.
Okay, that's great. I think a few months is wonderful.
Yeah.
Week is better than an elective course, right?
Yeah.
What do you do with them? Do you take them with
We see patients together. We
Okay.
discuss cases, and we discuss the science of addiction, the art of addiction treatment. So I try to impart unto them the skills they will need to survive in the medical world out there, in the medical community. To impart unto them the skills they will need when they see patients who present with an addiction, and tell the doctor, I've got a problem with this, or this or that, or who present while hiding their addiction. They don't want the doctor to know they have an addiction. They don't want the world to know that they have an addiction condition. So it's up to the doctor to be able to recognize this,
Right.
in order to help that person.
And what are some ways that you teach your students how to recognize it? What has worked for you?
I don't know. It's patented. I can't tell you.
I tell you.
I don't know. That's a heavy question. I wing it. I just go by whatever comes up. We dissect it, and we inspect it, and we look at it from all angles.
Absolutely.
So they learn some of the science of addiction. They learn some of the art of medicine, how to treat a patient, how to deal with a patient in order to gain a therapeutic alliance, right, and get some positive results.
Absolutely.
So there's a lot of things that we do, but I don't know if I can enumerate them.
Okay, Philip does have a question. He said, "Yeah." I said, "Philip, do you have any questions?"
Philip probably has a million questions.
He said, "Yes, thank you. To what extent are people with substance use disorder self-medicating for other psychiatric issues? What are some cases that you have seen that stand out?"
Well,
I can write a book, first of all, with doing.
You can write a book. You're very seldom going to see a patient with a substance use disorder that does not have an accompanying psychiatric condition, such as anxiety condition, mood disorder, maybe even a psychotic disorder. Very rarely are you going to find a pure addiction that has no other complications in the psychiatric world. They tend to coexist, right?
Absolutely. Yeah. And trauma has there's a lot of research now that, trauma is linked to, which we all know.
Trauma is at the center of many psychiatric presentations, including addiction.
Yeah.
Early life trauma, later life trauma. Yeah.
Let's see if there's a case that we can give as an example. We work with, a couple of the same clients, and, one that's extremely avoidant, is terrified to make any steps forward, or take any action. And that person has had addiction struggles and has underlying mental health struggles that have propelled the addiction. But still, now that the substance has been removed, all of those things are still there. And that's why this individual is still working with Dr. Morales, our psychologist, Dr. Hutman, working with a coach, working with a nutritionist. Because sometimes when you remove, in a lot of cases that we see, which is more predominant, the mental health diagnosis, or was the substances creating the more mental health? For me,
they feed off each other.
Yeah.
They feed off each other. Yeah. And they complicate each other.
I was given at 23 years old, I was put in South County Mental Hospital, and I was given 8 psych meds, and I was labeled bipolar. And I did not, once I took out the substances, I only needed 1 antidepressant. You know what I mean? So for me, they wanted to, and I was okay diagnosing me with any mental health diagnosis, because I didn't want to have to stop using drugs and alcohol. We have some more questions. So Susan Swanson, who is a lovely coach companion that has done work with us, and we love her. She said, what do you prescribe for patients, or what treatment modalities do you suggest? 12 steps, other programs, medication? What is your opinion on the available options?
Anything that's available, everything works. And for some people, the answer might lie in medication. For some others, it may lie in AA or NA. For another group, it may consist of both medication and AA, medications and therapy and AA, any combination of these modalities, whatever it takes.
Coaching.
I'm sorry?
Therapy and coaching and
therapy and coaching. Any modality.
Having everyone communicate. There's such a benefit in having your team communicate on your behalf.
Yes. We tend to treat treatment. For example, in the residential or inpatient setting, we have a treatment team, right? That team can be replicated on the outside as well for the outpatient. You have to have multidisciplinary input in order to get the best outcome for a patient. And there's no one size fits all. You can't treat every patient with the same formula. Some people require more of this or more of that. For example, more medication or more therapy. And then in therapy, there are many different kinds of therapies, many different therapy avenues that one can employ.
Right. I know that we like to do creative things, like Blake's kind of MO for some of the young adults that won't open up. He takes them to the rage room where they can go break things, and they make it like a therapeutic kind of thing, like what is in you that you want to smash, and that's the somatic work, and that works with people that have trouble sitting face to face and opening up, so we get creative. So what do you think of the things that are out there? Do you think that there's good options today for people? Are you comfortable with like the different options? Because it seems like, since I got sober in 2007, there's tremendous more of pathways and ways to do recovery than there were for me. It was black and white, and it was this way or no way. And I think that we've also shifted in behavioral health and people in recovery, that there's a wide spectrum of things that you can do now to get help.
Yeah, the chances of success in recovery are higher now than in the past, because there is more available, and because we've kind of taken a little bit of the stigma away and made it a little easier to come forth and say, I've got a problem.
Yeah.
We made it a little easier, but we still have a long way to go. But we use all these different modalities, as you mentioned, and as many modalities as are needed, we'll put into the mix.
Absolutely. And kind of trial and, you can, we have you do psych evals for us, and, sometimes it's recommended from you and Dr. Hutman, then we implement it, and if certain things aren't working, then we kind of move things around. Right?
Yeah, if something is not working, you got to change it. All right.
Yeah. Maybe they need more coaching. Maybe they need more accountability. Maybe they need their meds to see, the meds aren't right and they need to see you more often. It's everything's case by case. I think that was one problem. I think you could probably agree that every person was kind of treated this is the way. And I think that it's much more cutting edge now that we're looking at the individual, and
every person is a snowflake, and you got to treat that snowflake as it is. And it's different.
Different, right? Like what person comes in your office.
What does this person need? Yeah. What does this particular person need? Yeah. Right. You can't go by some set formula or something. you have to go with what you got before you.
Have you seen that evolve, like in the work you do and programs?
Yeah, I think that's always been, medicine is always very good about that. We're always improving. And when I say medicine, I also mean, I include the psychology world as well. Therapy is always improving. And we zero in on what seems to be working. And we switch from one modality to another. For example, you can be doing CBT with a person and change it and say, no, I think we should do DBT instead. There are many different things, motivational interviewing, so many different modalities that can be employed simultaneously. In addition to a medication, if a medication is warranted and if a medication can improve the odds of success, then we'll use a medication.
Love that. Yeah, that's great. And I know you're not someone that likes to over medicate, right?
You can never over medicate, nor you can't over medicate nor under medicate. You have to medicate. In other words, if you're going to do it, you do it right. You don't overdo it, and you don't give them too little that it won't do anything. So you have to know what you're doing as far as how much to use, or when to use it.
Yes, exactly. One thing that always stumps me is, someone will just come off of, heroin and all these hard drugs, and then they say, I don't want to be on anything. And I'm like,
right.
If you're going to take one little pill a day, like to help you balance and make things easier for you, when you were just sticking whatever in your body for years, it's kind of baffling to me. But we do have a few more questions. Ronnie Costa, who is a colleague that owns a business similar to ours and is such a great resource and connection. And we have Sarah and I have the best relationship with him. We want him on our team, but maybe someday. Is it true that ER doctors currently and historically have less than 10 hours of training on addiction? Do you know that?
They probably have 0 hours of training. But what they learn on the job, but they learn it on their own. They don't have the benefit of didactic from trained personnel.
Right.
So they learn what they learn, which is better than not knowing anything at all. But what they learn could not be exactly correct.
Yes, agreed. And then, like we talked about earlier in this, was the on the job, on the job. You can kind of get thrown in there, and okay, here's addiction. But then, I also see that desensitization, they're desensitized in emergency rooms, because of what they see, and then they get I've heard doctors express of being frustrated of like how many people come in with overdoses and so we also have to be gentle and kind and compassionate.
The ER docs, unless they're trained, will develop what we call a negative countertransference to the patient, meaning that they will say, look at this bum coming back into my emergency room again. What's the matter with him?
Yeah.
That kind of condescending attitude, because they don't understand that patient in the emergency room never woke up one day and said, I want to be addicted to drug X, Y, or Z. Or, I would like to become addicted to alcohol. Nobody ever sets out to do that.
No, that was never my intention.
Instead, they find themselves in a predicament like, how the hell did I get here? And how do I jump off this wagon train now?
Right.
But the doctors who see them, doctors who don't have the training, will view them as having some sort of moral failing. Like, what is wrong with you that you ended up this way?
Right.
There's something wrong with you as an individual, your moral values, etc. That doesn't work. That's not that way.
Right. And then it adds to the shame of the person. Then the person doesn't feel like they can go to a professional for help. So it is important for that compassion. Okay, I have another comment. In my experience, patients that have presented with past addiction disorders have major problems finding a PCP. They're considered problem patients, and PCPs don't want to take them on. So unfortunate, folks need help. And when they're denied that help, they spiral deeper into the problem.
That's correct. You have to find a PCP that understands, comprehends, or is sympathetic to the plight of the patient with a substance use disorder. And if you find one, keep them. If you don't, you might need to keep looking. But the doctor-patient relationship is very important. We've lost that nowadays because of insurance regulations and the way the marketplace is. In the past, people would get better just by the virtue of having a doctor-patient relationship.
Yeah,
No matter what modality you used, people will get better just based on the relationship that the two individuals form. But in
absolutely.
today's medical marketplace, a patient might have to switch doctors because my insurance changed. Well, they don't take my insurance here. I got to go over there then.
That's
So,
me.
yeah.
That's exactly what happened with me. I had the best doctor that spent his name is Dr. Angel Feliciano in Delray. And he takes time with patients, great, really knew me, knew my family, like what you really want. And then their practice was bought by another group and they stopped taking my insurance. And so for
See?
a year, I've been looking for a new doctor. I know one thing is I don't say for Nikki, like I don't say in my consultation with a new doctor that I'm in recovery. I do once I'm there, I let them know. But like if the people are getting turned away because they're saying on the phone that they have problems with addiction, that's awful. I think maybe not saying it on the front end, just giving your insurance information and getting in there and then letting them know, what the struggles are, what you have. Like I just tell my doctors to be safe. I'm like, listen, I'm in recovery for 16 years. Just thought you might want to know, just for anything moving forward.
Yeah, that's a good point. And then hope that the doctor has some empathy about that, or some understanding at least about that.
Yeah. I mean, some I don't think do. I know that, like so you have specific credentials. You're a fellow ASAM. Can you explain what that is?
Well, there are two ways to get specialty certification in medicine. One is through the Board of Psychiatry and American Board of Psychiatry and Neurology. And so a psychiatrist can get a subspecialty certification, board certification in addiction psychiatry, which I have. You can also get the board specialty certification in addiction medicine.
Right.
There's two avenues, medicine or psychiatry. I happen to have that one as well. And is there a third one? No, those are the two.
Okay.
And the ASAM is the American Society of Addiction Medicine. They've been around forever, and I have the privilege of having a fellow standing with them.
Which means what?
Fellow means that I've been around long enough that I've seen almost everything. That's what that means. I've been there for a long time. So you gain some seniority. You've been around. You've seen almost everything. Almost everything. I say almost because you never know what's around the corner. I might see something I've never seen before.
Very true. But so is there do you get voted into that? Do you just get provoked?
No, I think the fellow is just based on time alone. But time and certification. If you have the right certification and you've been there long enough, maybe 15, 20 years, I don't know what it is, they give you that accolade and say, hey, you can tack this onto your name. You're a fellow now.
That's incredible. And so what your background, share just the things your specific education that you've done.
Specific education. Well, I'll tell you, my interest in addiction arose from my interest in chemistry, in biochemistry, because I see patients who are using or drinking. I see them as using their brain as a pharmacology lab, what we used to do in school. My undergraduate degree was from College of Pharmacy. I was a pharmacist for several years, and I found it too boring. I said, this is not for me. I got to do something else. Yes. So my background is in chemistry, and so I recognize what these drugs are doing to people's brains, and that piqued my interest. I also had, and I think it worked in my favor, working in the music industry. A lot of my patients are famous. Well, a lot of my friends, I should say, are famous, and some are dead. Because I've been around these guys that were using drugs all the time. I wouldn't touch them. I was scared of that, but that's just my own personality, whatever. But
for you.
So when I see patients with addiction, they don't scare me because I've been hanging around them all my life. Well, a lot of musicians have addiction problems, but I know that they're nice people. I don't say, oh, look at this guy. He's terrible. He's a jerk or whatever. No, these are guys that I hang out with, the guys that I play with, guys whom I admire.
Absolutely.
And they have an addiction problem, so I understand that. Then when you get trained and you see the role of maybe they have some trauma in their life. Maybe trauma led them to discover addiction. Who knows?
Yeah.
But they're just a fellow human being.
Yes, absolutely. Human beings. That's why, I hear often, you don't look like someone that's an addict. And that's what I'm like, what
Right.
does that look like?
What does an addict look like?
First of all, if you saw me when I first came into recovery, you may
Yeah.
say singing a different tune. However,
Yeah.
like there is this stereotypical, like, alcoholic is a little bit more accepted these days. But if you have addictions, substance use disorder, that's still very stigmatized, especially as a female.
Yeah.
There's a lot of like shame that a lot of women mothers carry with that. I know that's a lot of the work that I do. And like the face of an addict is this. The face of an addict, it can be the most successful, educated, whatever person. It can also be the person that's under the bridge, but they didn't start there. They got there from, who knows like how they ended up there. But it affects all of us, our friends, our family, our coworkers, our doctors, our lawyers, our flight attendants, does not discriminate, on social status or education or any of that. And
Yeah,
you are brilliant, talented people.
Yeah, it's an equal opportunity condition.
Absolutely.
Anybody's at risk.
Yes. We do have Susan has another question, which is something I think you could definitely help. Are there any medical publications with studies which focus on addiction that you would recommend? I love studies. I have a biochemistry degree, and I find stats very interesting. Stats such as outcomes dependent on length of treatment, stats on medication responses, etc.
I can't quote you a specific study, but you might want to look up any of the writings of Charles O'Brien from University of Pennsylvania. Charles O'Brien. You might want to look up Kosten, Kosten, Nora Volkow, Volkow. Who else comes to? If you want to get real sophisticated, the head of the psychopharmacology unit of the NIDA, I'm blanking on his name now. I'm blanking on a lot of things lately. It's either my age is creeping up on me, or I have a post-COVID fog that I haven't totally cleared from yet.
Who was the first one you said? Just because I'm typing it in the context.
The first one I said Charles O'Brien.
Okay, from Pennsylvania.
Yeah, University of Pennsylvania. Also, Dr. Kosten, Kosten. I forgot his first name.
Him already.
Who else did I say?
The last one you couldn't remember.
Well, this one, if you're really into the science of it, the head of the psychopharmacology unit at NIDA, what's his name? I'm blanking on his name. Hopefully, it'll come to me before the session is over. And I said Nora Volkow,
Yes.
Volkow, who they've done a lot of research and published lots of works. And if you're interested in the biochemistry or the science of this, look there.
Awesome. Okay, Susan corrected. Thank you, Susan, for correcting my error. I was trying to type as just so people have. So if you want to do that research, so what are you working on with your students right now? Like, what are you doing with them today?
Today, I'm not doing anything specifically because I'm here and they're over there.
Okay.
They're actually seeing patients and I'm here with you. But what we do is look at cases and then we study the science behind the case, how that led to where they are. And then we look at what are the treatment modalities we can put in place to help this person as an individual, because everybody's different. What does this person need as opposed to that person that we just saw 5 minutes ago? So we individualize it.
That's great. And talk about the different cases. I could talk to the team, but I would love to potentially, if you ever want to talk about any of our cases we have together, I would be willing to do that. And they could see from like how we collaborate and how we work together. So just putting that out there.
We could do that. We just present the case without the names. Yeah, you could do that.
Exactly. Just talking about the client and what, you're doing with them medically, what Dr. Hutman's doing with them clinically, what their in-person coach is doing, what role.
You know what you can also do? people can present a case for an opinion.
Yeah, I love that. I'd
Yeah.
love to get that.
Yeah. Because in other words, here's a difficult case, or here's a case that I'm dealing with, and we're stuck and we're not making any headway. What can I offer? We'll see.
Right. That's great. Awesome. So you can find Dr. Morales. He is on LinkedIn. Dr. Morales, how can people find you on the internet if they wanted to like schedule if you're looking for a good psychiatrist in Boca Raton? Or anywhere in Florida, Dr. Morales is the one.
Amanda, I am not as tech savvy as you are. I write with a quill that I dip into the inkwell by candlelight. Yeah. All right. So I don't have a website.
But you are on multiple websites. Like if you look on like Health Grades or like Psychology, you're like on all that stuff. So
I don't know. I don't know who put me there, but I guess I am. I don't know.
Yeah, you're there.
I don't have a self-promotion campaign. So wherever I exist, somebody put me there.
Well, we're very lucky that we found you and that we have you on our team. Oh, Dr. Jeffrey Hutman's here. He said, "Hi guys, great to listen. I'm curious what Dr. Morales thinks about those with substance use disorder being prescribed gabapentin."
Oh, that's a great question. See, that's one of those gray areas. Because the gabapentin is a controlled drug in about 5 or 6 states now. And at some point, it's going to become a controlled drug everywhere. So here's the deal with gabapentin. Some patients are misusing it because they like it and because it does something for them, right? And those patients cannot have gabapentin, no matter how good they think that it helps them. Those patients for whom the gabapentin hits the spot and they are liking it too much, they cannot have it. Now, there are patients in whom we use gabapentin and they have no liking. They have no like for it. And those patients can take gabapentin probably okay. I said probably because only time will tell if at some point they cross the line and they begin to misuse it. It has a likability factor, but not as much as Valium does, for example. The Valium likability factor is up here. The gabapentin likability factor is way down here. And it depends on the person. So there are some people that I can use gabapentin and get away with it, right? And there are others that I wouldn't touch them with a 10-foot pole of gabapentin. No way you can have gabapentin. So it depends. It depends on the case.
Depends on
the interesting thing would be if it becomes controlled nationwide, and then what do we do? Now it's prescribing a controlled substance to somebody, and that can be a little tricky because it puts us on guard.
Have there been changes with like how doctors prescribe like more carefully in the past years, like from the behind the scenes that, or are doctors just using their better discretion moving forward?
Well, lately the pendulum is swinging in the direction that doctors don't want to prescribe, and many doctors, I shouldn't say doctors in general, but many doctors don't want to prescribe benzodiazepines or anything controlled. They'll say, go see a specialist. If you want a Xanax, go see a psychiatrist. If you want a pain medicine, go see a pain management doctor. I'm not going to touch that with a 10-foot pole because it's too much potential trouble.
Absolutely.
So I'm seeing that quite a bit. Here's the other thing, the irony that happens with medicine. For example, you remember the medication Soma?
Yes.
Soma, caricipridol, is a skeletal muscle relaxant.
Yeah.
And Soma is a controlled drug today, but it was not years ago.
No, it was not.
It became controlled somewhat recently in the history of medicine.
Yeah.
Before Soma became controlled, the irony was that in your system, Soma was metabolized to meprobamate, which is a controlled drug. So you could take a drug that is not controlled, and you could get it prescribed freely, and once you put it in your system, it becomes a controlled drug in your body.
Yeah, that's interesting.
So eventually they got around to fixing it, and now Soma is a controlled drug because a lot of people will misuse it. It has a likability factor.
I think you said something that was a huge, important thing for me. I think seeing your primary care doctor for psychiatric medications is not a good idea. That's like me going to the dentist for a foot problem.
Yes and no. It's a good point you raised. Look, if it's a easy situation and your family doc is somewhat savvy about
Yes.
anxiety and depressive disorder,
Yeah.
they can handle it, and
Antidepressant.
they can refer to a specialist if they get into trouble, or if they're not getting results. So it's okay. It's okay as long as the doc knows their limitations, and at some point they'll say, I have to refer you to a higher up because I'm up to here with your case. I don't know where to go after this.
Right. I
Uh,
just seen clients, just kind of go to their and kind of say like that I have, I'm depressed or whatever. And I just feel that in an emergency situation, or like you said, ones that are savvy, I think that's okay. But when you're seeing people with chronic mental health struggles and they're yet to go see the person that specializes in mental health, that I always encourage people to see a psychiatrist or for psychiatrist.
it's always good. Here's the other thing I see: a person gets diagnosed with a condition, say depression or anxiety, the common things,
Yes.
and they get prescribed a medication by a psychiatrist, and then they say, you know what, I can go see my primary care doctor, and they can give me this prescription, and then they stay on it for years and years. They just keep getting the prescription refilled. The question is, does the patient still need it? You see,
Right.
you don't need to be on something forever. There are times that you do. There are cases when you do want the medication forever, but there are times that you don't. So unless they have the benefit of a specialist looking at it, they might stay on a drug longer than they're supposed to.
Yeah, agreed. I agreed. Dr. Hutman has a comment back. He said, I have seen some doctors prescribing high doses above 3,600 milligrams routinely and not considering how much the patient may be seeking a euphoric effect from it. And then he said, interesting point about soma.
I guess the 3,600 milligrams, it must be about gabapentin.
Yes.
Anybody who's taking that much gabapentin is a red flag. You have to look into it much more carefully, and chances are there's a problem is lurking there.
That's really high. I was prescribed a short term of it for a nerve thing, like a sciatic pain, but it was like 100 milligrams or something like that. It was tiny.
Well, like I said, not everybody has a problem with gabapentin. There are patients for whom it doesn't hit the spot, so to speak.
Yeah.
By that I mean it doesn't create the kind of euphoria that they say, I'd like to have some more of this. There are some patients that don't get that, and for them it's a safe drug.
Right. Makes sense.
But for others who have a euphorogenic response to it, they can't go there.
This is interesting. Ronnie Costa, who's all over the country, but LA based, said GABA has been heavily abused in the California jail system for at least 10 years. And I am aware of, because inmates can have it and they can't have narcotics. Some inmates are given close to 2,000 milligrams a day.
Wow. Yeah. They also use a lot of Seroquel in the prison system because Seroquel is available. It's not controlled, but high doses of Seroquel behave a little bit like a hallucinogenic.
Yeah. So what would you like to share with anyone that is seeking mental health help? Like, what should they be looking for? And like, where should they start?
Okay. I like board certified psychiatrists, right? As opposed to a general psychiatrist. I like that. I like that better than a general practitioner. If you have an addiction issue, then you should seek someone with addiction credentials, like a board certified addiction psychiatrist, board certified addiction medicine doctor. Because if you go to your regular doc down the block, they may not know about this. As we discussed earlier, they're just beginning to learn this now in medical school. They may not have been trained in this area. So if you have an addiction problem, look for someone with addiction credentials. If you have any kind of psychiatric problem, try to get a board certified physician rather than a non-board certified physician.
Good call. And what is your favorite, or what are you most excited about in the change that you're seeing with, medical students being required to learn about addiction? Like what is that?
Just the mere fact that it's on the radar, and that when we present it to the student and residents, it resonates with them because they know this is out there, and why didn't we get this sooner?
That's great. So you're getting really good responses from it.
Exactly.
Awesome. And is there anything else you'd like to share with everyone? Any kind of closing comments or anything that's just on your heart? Or
Well, closing comments. I thank you very much for inviting me here. You do great work, and thank you.
yes, we're big Aldo Morales fans, Sarah, Blake, and I, and Dr. Jeffrey Hutman. We adore you. We think that you are the best of the best. I really wish that you could just teach all the psychiatrists out there, good, I mean, honestly, I mean, I've worked with a lot of them in my career, and some are just not polite. Some of them are not, personable. Some of them are not as, compassion, like educated through a compassionate lens like you are. And it's truly a gift for anyone that gets to have you as their psychiatrist. So I mean that from the bottom of my heart. I think the world of you. And if anyone, needs a good psychiatrist, this is the one. We're great.
I'm gonna make you the president of my fan club, Amanda.
Well, I think Sarah and I may fist fight over that one.
All right.
We both adore you, but thank you so much for your time and your energy today, and to your students that work with you. You guys have the best of the best, and I look forward to many years ahead of me finally coming to see you play music and us continuing to work more and more clients' cases together, because we do great work as a team.
Yeah, absolutely.
Awesome. Thank you, everyone, and we'll put in the chat a link of some kind of to find Dr. Morales, and I'll also add his profile here. Thank you, everyone, for your awesome questions. I'm Amanda Marino with Next Level Recovery Associates. You can find me on Instagram, Amanda Marino Recovery. Same thing on other profiles, just Amanda Marino. And Next Level Recovery Associates is our company. Case management, 24/7 live-in recovery companions, interventions, consulting. We do a lot of interesting, fun things, and we're really grateful to do the work that we do. So thank you all, and have a lovely Tuesday. And thank you, Dr. Morales.
Thank you. Okay.
Have a great day, everyone.